Hello and welcome back to another episode of the Pro-Life Hour. My name is Father Thomas Lynch and I'm the president of Priests for Life Canada. As many of you know, Priests for Life Canada is an association of Canadian Catholic clergy, bishops, priests and deacons, and also lay people who promote and defend the sanctity of human life from conception to natural death. We work to support, inform, and empower Catholic clergy, build a culture of life, and we bring together clergy and all Catholics to fight the culture of death, particularly abortion and euthanasia. One of the ways we do this is by this podcast that we call the Pro-Life Hour. It will be available on our website and our social media platforms on the second Thursday of every month. In addition to hosting this podcast, we also produce informative bi-monthly newsletters, provide clergy homily notes for Sunday Mass readings, provide parishes with free pro-life material as part of the Just for Life program, and host special congresses and symposiums that bring together both clergy and seminarians. As usual, I'm joined by my co-host, Father John Lemire of Sacred Heart Parish in Timmins. Welcome, Father John.
Thank you very much, Father Tom. Always good to be with you.
And before I introduce our guest today, let us begin with a prayer. Heavenly Father, you formed in your image and likeness every man, woman, and child. Give us, we beg you, a keen eye to recognize that image, so that respect for all human life becomes our way of life, that together we defend least among us. Grant this through Christ our Lord. Amen.
Amen.
Well, we're very pleased to welcome to our program today Dr. Leonie Herx. Dr. Herx completed her medical degree at the University of Calgary, followed by family medicine and palliative medicine residency programs. In her early days as a doctor, she worked for 10 years in palliative medicine at the University of Calgary, serving in numerous roles, including palliative medicine residency director and medical director of the intensive palliative care unit at Foothills Medical Center. He has worked in both adult and pediatric palliative medicine. In 2018, Dr. Leonie joined the palliative care team in Kingston with the focus of her clinical work on providing consultative palliative care support at the Kingston Health Sciences Center and Providence Care Hospital. She serves as the head of the Division of Palliative Medicine at Queen's University, where she is also as an associate professor. She's also the clinical director of palliative care at Providence Care and the medical director at the Kingston Health Sciences Center. She's been on the board of the Canadian Society of the Palliative Care Physicians for the last 8 years and is currently its past president. She's been married for 21 years to her husband, Chris, and is the mother of 6 wonderful children. Well, welcome, Dr. Leonie. It's good to have you with us today, and we thank you for making time for us in your busy schedule.
Thank you so much for having me. It's a pleasure.
Well, I wonder if you could share with our listeners what initially attracted you to pursue a career in medicine, as well as your decision then to specialize in palliative care.
Absolutely. I fell in love with medicine actually in high school. So it goes back a long way. I think just part of my personality and my natural talents that I was given. But I certainly really was drawn to biology. And during that time, I found myself really needing to be caring for people at the same time. So I knew that I was loving science, but I ended up volunteering throughout all of my high school. And high school in Nova Scotia is from grade 7 to 12. So for many years, I volunteered in a long-term care center and ended up taking care of patients with advanced dementia in the memory unit. And what really just impacted me, I think, forever and led me to this path on palliative care is just that great sense of appreciation I grew for the inherent dignity of each person, even those people who weren't, their usual selves with severe dementia. They had such great quality of life and moments of pure joy, and it was just I learned a lot actually by taking care of those people and being a witness to just the hope and resilience that is just part of the human nature. So I think all of those kind of came together in university and led me to palliative care. I volunteered in palliative care throughout my undergraduate degrees and even through graduate school before starting medicine. It was that whole person care that really struck me about palliative care and being able to take care of the whole person in physical, psychological, emotional, in the context of their family, what makes them uniquely human, and in the ways that they see the world. It's just such a privilege to be able to come alongside people in that way in the form of science and in medicine. There's not a lot of areas of medicine that allow you to or promote, I guess. So you can always practice medicine in your own way, but that promotes that whole person care that's really what I enjoy so much about palliative care.
Really? Father John?
Well, Dr. Leonie, we hear an awful lot about this term palliative care, but it's sometimes hard for people to kind of grasp fully what it is. Can you maybe share with our listeners a little bit about what palliative care is and also what it isn't, and then what you do as a palliative care physician?
Thank you. That's a very important question. In fact, palliative care has been quite misunderstood, especially over the past 5 or 6 years since the legalization of euthanasia. Palliative care is whole person care, as I described, that focuses on improving quality of life for those living with life-threatening or life-limiting conditions. It's often thought of in the context of hospice, which is one part of palliative care at the very end of a person's life. But palliative care is actually best integrated early into a person's illness journey and can help people navigate complex decision-making, support them in understanding their goals and wishes for care, reduce the burden of unnecessary treatments. It really affirms life and sees dying as a normal part of life. It focuses on living well until a person's natural death. To do that, we provide impeccable symptom assessment and management and provide supportive care for issues across the whole person, including the physical, well-being, psychosocial, emotional, and spiritual, as I mentioned earlier. And very importantly, one of the core principles of palliative care is that it doesn't hasten death. There's a lot of myths around palliative care that we give, high doses of opioids such as morphine at the end of life that kind of speeds things along, or we use tools such as something called palliative sedation, which is been misunderstood to be a form of euthanasia. In fact, palliative care works very carefully and diligently to use the medications in just the right amount to alleviate the symptoms that come about with different types of illnesses, such as pain, shortness of breath, that might accompany cancer, for example. But it does not actually shorten life or hasten death when followed according to evidence-based medical standards. And so there's a lot of myths that have been long-standing in the community around palliative care, and that has caused this conflation with euthanasia because of that thought that we give these high doses of medicine that kills people. That's actually not true. And it's been one of the barriers to people accessing palliative care early is because they think it means that you're dying, or we might speed things along when actually when palliative care is started early, it has been shown to not only improve well-being, reduce anxiety and depression, improve symptom management. It has been shown to reduce the amount of unnecessary tests. And in some cases, people actually live longer, reduce caregiver burden, and help people feel more satisfied with their care because it's more congruent with what their goals and wishes are. So it's quite striking that it can make such a big difference for people in the quality of their life all the way through until they die, but only 20 to 30% of Canadians have access to palliative care. But yet, most people want to die a natural death. The death rates of euthanasia in Canada are about 2% of all deaths. So it's just, quite shocking and sad, really, that we haven't worked to increase access to quality palliative care when it can make such a difference for people.
It sounds really as if somebody would automatically want that. Wouldn't you agree, Father John?
Mm-hmm.
Yeah, and I think the way, Dr. Leonie, that you've described it to our listeners of this idea that palliative care actually helps improve the quality of life for the patient as well as their families, and yet so often society does not see it in that light. Can you just elaborate a little bit more about how it improves that quality for the patient in particular, especially when they come in at early stages?
Absolutely. So any serious illness or life-limiting illness, there are times where you have symptoms that come about because of your illness. It could be if you have COPD, for example, heart failure, if you have cancer. At intermittent times, you may have some symptoms that come about while you're getting treatment for your condition. You could get like nausea and vomiting as side effects of your treatment, or you could have some worsening periods of shortness of breath. You might have concurrent infection like a pneumonia. And so palliative care can work to reduce those symptoms by providing very, diligent symptom assessment and using medications to control pain, to control shortness of breath. but also to control anxiety and mood, which we know are altered when people are facing very difficult times. And not just with medication, through providing that whole person care, through supportive counseling, through different techniques around mindfulness, breathing exercises, lots of non-pharmacological, and just being a supportive presence to help people get to the heart of their suffering. Because suffering in our human beings form is not just physical; it's often a mixture of emotional, psychological, spiritual, existential, and physical all mixed together. And so palliative care experts, work really hard and are trained to really figure out and accompany people in their suffering to help them identify what it is that's really affecting them so much. It may be manifested as physical pain, but it might be that you're worrying about what dying might be like, or you're worrying about leaving one of your loved ones behind, or about being a burden to someone because you've been the breadwinner or the caregiver your whole life. And so oftentimes what we're doing is exploring with people how they find hope and resilience in past challenges, and helping people navigate those complex decisions to make choices that are good for them, and to help their families and caregivers understand what matters to them and what they're worried about as well. So we approach a person on all those levels at the same time. We don't just provide physical care. It's all those aspects that are intertwined in us as a human being.
Is it not often the case, and very often the case, that really when it comes down to it, it's the fear of that loss of control, that fear of psychological or suffering or social isolation that can lead to many of the requests for mercy killing?
That's right. So the Canadian data for patients or for persons who request MAID, which is medical assistance in dying, which is euthanasia, that's the euphemistic term we use in Canada, is the same internationally. The data shows that all requests for euthanasia are a result of psychological suffering or fear, existential worry. It's not due to uncontrolled physical symptoms, which is the opposite of what the media portrays. They make it sound like it's people writhing in pain who can't breathe. That's not true at all, as I said, nationally or internationally. It is often fear around what dying might be like, because we don't talk about it in our society anymore. We don't see it. So that's one thing that I think, we can come to, that we really need to help people understand what natural dying looks like. And it's actually not scary, and it doesn't need to be uncomfortable. So that's one really important aspect. It's also due to fear of being a burden to other people, or fear of what symptoms might come, like fear of pain as opposed to pain itself. So again, education is really important to help people understand what palliative care has to offer, how we can control symptoms, through our very diligent, impeccable symptom assessment and management. And we've come a long way in our advances for managing even the most complex symptoms in palliative care. So there's no reason for someone to have poorly controlled symptoms or to be, in any kind of extreme pain or shortness of breath or anything throughout their illness, not just when you're dying. So that's another really important thing, that we can alleviate some of that fear by providing education and helping people understand what options are available to them. And options such as when, treatments are too burdensome to give benefit, that's an absolutely acceptable time to stop treatments that are causing harm. That's not the same thing as euthanasia. That's allowing the natural disease at the end of one's life to take its course. And so stopping something like dialysis or not doing antibiotics, those are very ethically appropriate choices that someone can make. And again, is not intentionally ending someone's life with a lethal injection, which is what euthanasia is. So education is so important. Yeah, sorry, go ahead.
But but this is still the shibboleth, that people are raising all the time about, I don't want to end in excruciating pain. Mm-hmm. I don't want the life of my life or the life of someone I love that way. And can you be a bit more specific about it to directly address that fear, that misconception? But what we do for those who are in pain and suffering with other symptoms?
Yes. So we have lots of medical tools that we use to provide excellent pain control. So it could be medications that are given by mouth, such as opioids, like stronger medications if necessary. We have lots of injectable types of medications if you have more severe pain and are not able to swallow, for example. we can do many interventions like epidural. So people think of epidurals for people who have babies. Well, if you have, severe pain, we can also use those types of interventions to control pain very well. And we can do nerve blocks. Like there's just lots of advances in our ability to control people's pain. I've not had a case in my 15 years in palliative medicine practice where I've not been able to provide a person with symptom relief. We've just come so far in how we can alleviate symptoms and control pain. And we do have at the very end of life, if it's necessary, a tool called palliative sedation, which is a way of keeping a person comfortable in their last days of life, if we can't control their symptoms in another way. And it is medication used to lower the level of consciousness just as needed, not into a deep sleep. Sometimes people can be very awake, so that they can have their symptoms controlled. And when done very carefully according to those, particular protocols that a palliative medicine specialist needs to approve, there is no shortening of life. We've shown that in randomized control trials. So it is a very safe, effective tool in those very extreme circumstances, but it's very rarely does it have to be used. So there's always something that we can do to keep people comfortable and to control their symptoms. I did want to add one thing to your question earlier about causes for euthanasia, and that is that fear of being a burden to others. And most often just facilitating a conversation with a person's family or caregivers or community of support around what the person's worries are, and having the family be part of that and say, actually, it's an honor to be part of your care. And it's most often just facilitating that conversation and the person hearing that they matter and it's meaningful for that person to be there to support them as they've supported them, all their life. And so I see that very often that, just communicating and helping people have that difficult conversation and expressing their fears and worries is often enough to alleviate that sense of being a burden.
Right. Brother John?
Well, certainly with everything that you've been sharing with us, Dr. Leonie, there's so many benefits of palliative care to help both the patient as well as their families. And yet we know that palliative care is not always that accessible in our country. Can you talk a little bit about that accessibility in particular here in Canada and perhaps why it's not so accessible if there's so many blessings and benefits that come about from it?
Yes, we've known for a long time. In Canada, we've had palliative care for over 40 years. And certainly over the last 20 years, we've shown the significant benefits, both on quality of life and then most recently, as I said, even on sometimes length of life and reducing healthcare costs, which is just a bonus, really. But there's not been the investment from the level of the government and the commitment across education, both to all healthcare professionals, not just in med school and residency, to help people be equipped to provide palliative approach to care for all their patients, and then access to the specialists like myself for those more complex cases. So the Canada Health Act does not actually include palliative care or home care supports in it. So there's no obligation for provinces to fund palliative care as there is for MAID. So when MAID was legalized, euthanasia was legalized under C-14 in 2016, it was made part of the Canada Health Act, and provinces had to fund it and show how they were meeting the need for every person to have access to it. But it's just atrocious that palliative care has not been afforded the same right when 98% of people who die are not choosing euthanasia. And because of the benefits and even the healthcare cost reduction, we've been advocating for decades for the government to make sure palliative care is accessible. We just haven't seen the follow through. I don't know what the barriers are because over time it does reduce costs, but it just hasn't been a priority. And I think now we have a wake up call, we have now through C7, euthanasia being offered to people who don't even have a life-limiting condition, who could have many decades left to live, and we're choosing to offer people death instead of supports needed to live, like home care and disability supports. Just like palliative care, they're not part of the Canada Health Act. Medical schools, it's not well integrated, the training for palliative care. Throughout medical school, it's the same for nursing and all other healthcare professionals. So that's one thing we're really trying to work on now through the new National Palliative Care Framework. It hasn't come with funding, but we're at least trying to articulate that there needs to be general competencies embedded into every training program so that all healthcare professionals have basic training in palliative care, and then improve the access to the specialists like me. But we still have a long way to go, and I think we need a bit of a public outcry about it and demanding our politicians to make it a reality for our Canadians.
But do you see then with the legalization, and this is Bill C-7 that you'd mentioned, that has expanded the access to, I hate using the term medical assistance in dying, so expanded the access to mercy killing and euthanasia. What impact has that had on the work that you and your colleagues do as you work and minister to these patients?
Mm-hmm. Yeah, so it's had quite a significant impact in my experience, and many of my colleagues have had similar experiences as well. So it's quite alarming how this offering of euthanasia, and I say offering very intentionally, has become very normalized as a response to any type of suffering. And so we now find ourselves in instances where a patient actually has poorly controlled symptoms and needs a palliative approach to care and possibly even a specialist palliative care lens to get their symptoms under control. Often earlier in their disease trajectory, we're not even talking about towards end of life. And a person expresses, a desire to die, which is a very normal expression of grief or lament or anger about the situation or just, having poorly controlled pain. It's very normal to say, I wish this was over. And now we see kind of a knee-jerk reaction where the euthanasia team is called in right away before a person even sees palliative care or before their own team, gets their symptoms under control. And it just becomes the easy answer to any type of suffering. So we see that now with C7 expanded to any type of suffering, whether it's from disability, chronic illness, and soon to be mental illness. Mm-hmm. That is cheaper and easier, really, than having increasing access to palliative care. And because people don't have the skills, they don't have the training and the understanding around how we can control symptoms, they, want to be able to do something. So they offer people euthanasia. We have many examples shared in the Canadian media, witnesses who testified at the Senate and House of Commons around Bill C-7 who described healthcare professionals or hospital staff offering them euthanasia and making judgments about their quality of life, often people with disabilities, rather than looking at what are the supports lacking in their life right now to help them live, right, or to live outside the hospital, for example. So it's quite shocking and quite difficult for us now to know that, we see people who haven't even had good symptom control or have the supports they need to help them live, like access to wheelchair or home care, but they're being offered euthanasia as the solution to the gaps in the healthcare system. And because most people, truly, they don't understand what's being offered to them when someone offers them MAID. It sounds like very nice, right? Medical assistance in dying. Who doesn't want assistance in dying and to be comfortable during the dying process? And right. Still, even 6 years into legalized euthanasia in Canada, I see patients every week who don't understand that when someone's offering them MAID or medical assistance in dying, it's a lethal injection to immediately end their life. They think they're asking for palliative care, like that concept of, please keep me comfortable. I don't want to have, poorly controlled pain. I want to be the most, peaceful I can be during this process. And they get kind of a bit hoodwinked into thinking that that's what they're getting.
Well, I think that, let's be frank here, the media right across this country, it really just did not cover the Senate hearings, for instance, didn't cover the parliamentary committee hearings, and have been basically presenting mercy killing as, this wonderful, exit to life surrounded by, the music of Brahms and, and flowers, right? It's instead of being honest about, well, what is really there. And unfortunately, I don't think many of them have been able to to really grasp it. I know I preached on it a number of times, and people will say, no, that's not what it is. It's this. It's only an extreme measure, and that's unfortunately not the case at all. I mean, are you finding that as well, though, that it's really clouding the concept of palliative care?
Definitely, I think, yes. Sorry, go ahead.
No, sorry. Go ahead.
Yes, I think because of that well, first of all, the euphemistic language, we've both, called that out in our talk today, that it's just very misleading what MAID is. We provide in palliative care. That's actually one of the core aspects of palliative care is end-of-life care, and we provide assistance in dying, make sure you're comfortable and you're have the best quality of life while you're dying. But we don't give a lethal injection to end someone's life. That's not palliative care. But it sounds like it is, right, when you say medical assistance in dying. And so it's caused a lot of confusion in the public, which, it's just people don't know what they're asking for, and then it's become very procedural. So euthanasia is being offered to people when they express a desire to die, when really they're needing someone to come alongside them and explore their suffering and what is going on in this instant, in this moment, in this story for this person that's causing them to think that they would be better off dead right now. It doesn't mean they're asking for a lethal injection, right? And so that taking that time to sit down and to support a person in understanding what's going on, and then making sure they're educated around how we can care for them, and what is really going on, that all takes time and expertise that people aren't getting access to. And so the easy tool is to say, well, let's offer them euthanasia. And I think, we're seeing the rates go up since legalization in 2016. Started off, I think, around 0.5%, and now we're over 2%. And in some pockets of the country, depending on the local culture around offering euthanasia and the normalization of it, like in Vancouver Island, we see rates as high as 6 to 7%, which
really?
took, which took other countries like the Netherlands, over 20 years to reach, levels of about 4%. But yeah, we were seeing very, significant regional variation, depending on the local medical culture.
Brother John?
Many of our listeners are aware that Bill C-7 sadly has just passed, and it's taken away even some of the very few safeguards that were there in the previous legislation, and it's expanded who can request mercy killing, and is continuing to lead us down that very slippery slope. Dr. Leonie, I know that you recently testified before the Senate Standing Committee that were reviewing the bill. Can you share with us a little bit about your experience of doing that and some of your concerns as a palliative care physician?
Yes, I testified to both the House of Commons Committee and the Senate. The Senate, I testified on behalf of the Canadian Society of Palliative Care Physicians, represented that national voice. And in that particular testimony, we expressed concern around numerous of the safeguards that are being removed. So we've not even had a proper study or review of how the current, well, it's not current anymore, how the past MAID regime, the euthanasia regime in Canada, was working under C-14. We're not asking any type of right questions to know who's being made vulnerable and how many wrongful deaths are occurring. And I would certainly think there are a number of wrongful deaths occurring based on the day-to-day practice that we've heard about before those committees from various experts that were really quite dismissed in the wording of the new legislation. So we expressed concern around the removal of the 10-day reflection period. So for those people that have a reasonably foreseeable death by the legislation definition, they no longer have to have a reflection period where when they make their written request for euthanasia and until the time where they get the lethal injection, they have this 10 days time to change their mind. Some of us would say 10 days isn't enough, but the medical evidence shows that most people change their minds when they express this desire to die or request euthanasia, and its average is about 2 weeks. So even 10 days could be considered too short, but certainly having that, a buffer of time to have some supports provided if you haven't had palliative care until this time, help people understand and come to terms with what's going on for themselves and change their minds. But without that, you could have someone who's in despair and expresses that desire to die and just can't see a way of living, and is offered MAID, and it can be provided on euthanasia, on the same day with this new legislation, Bill C-7. So there's no requirement for a reflection period. Someone could just in haste request it and get it. And I think that the euthanasia providers argued that, that's their job to make sure that it's not a person who's doing it in haste. But I think when you have someone who's depressed and overwhelmed, like, I'm not sure, and in desperation, I'm not sure that there's any safeguards they could put in that wouldn't prevent someone from having a wrongful death in that situation. Some of the other things we were concerned about is something called the waiver of final consent. So in the C-14 legislation, a person was required to have capacity and give consent for the procedure at the time they make the written request, and then again at the time of the procedure. And in the new legislation, they are allowed to have lost capacity and not give final consent now at the time of the procedure. So that would allow someone who's not able to say that's what I want now to have someone say, well, we made this previous agreement a few weeks ago that they were going to do this, and so now we're going to go ahead with that. So it's just incomprehensible to me that we would go ahead when someone cannot give a final consent with something so serious. I mean, when we know people change their minds. They had a case of a person in the Netherlands in the fall where it was a person with dementia. It was a bit of a different context because they had an advanced directive. This is a modified advanced directive that's allowed under C-7. But the medical professional decided, well, now this person's quality of life was so poor that they were going to go ahead with the advanced directive and end their life with euthanasia. And that person was combative and fighting them off, and they had to hold the person down and give the lethal dose of drugs. And so out of that came this new protocol called, which it seems like a silly name, but coffee euthanasia. That's the term they use in the Netherlands, where they give a sedative medication now to people who they fear might not understand what's going on and might become combative. So they slip it into their coffee or into their food or drink, and so that they won't be able to become combative and fight them off. In Canada, we have this weird wording in C-7 that says that if a person, expresses like physical movements and things that are might indicate that they don't want to go ahead with it, but that's left to the subjective interpretation of the MAID provider. And I don't know how any physician would be able to know whether something is like a person who can't speak for themselves fighting them off because they don't want MAID or euthanasia, or if it's like, an involuntary movement. Like, they have all these nuanced descriptions in the legislation that I think are going to be very difficult for physicians to interpret, whether or not someone is actually showing through their behavior that they are refusing the procedure. So that's another issue that we brought forward to the Senate. So sorry, go ahead. There's so many issues with this legislation. We could talk for a whole hour just on that. Yeah.
What the reaction of the senators were as you raised some of these issues.
I don't know that they really listened, and I say that very carefully. They were very intent on the only witnesses who mattered were the ones who have been on the ground providing euthanasia, which I find quite alarming because many of us have been living this on the ground with a different important perspective for the past 6 years as well. We've all been in the trenches caring for our patients and families and seeing the inadequacy of the safeguards just under C-14, never mind what they're proposing and what's now gone ahead under C-7. And so it was very discouraging to see that it was really only the people who have provided euthanasia that whose testimonies were really heard and taken to heart. And shockingly, not persons with disabilities or people who've been discriminated against and offered made and had lack of access to services, those persons' testimonies were also dismissed, along with those of us that have concerns. It definitely seemed that if you weren't championing for MAID, you were there to obstruct it, and that wasn't part of the agenda.
That's a rather scary analysis.
Mm-hmm. Yes, it was very disheartening because, the vast majority, if you go through and listen to the transcripts of the Senate pre-Senate hearings, so there was a whole week in November, and then there was another set of testimonies in February. The vast majority of those testimonies all expressed significant concern for the way the current legislature, back then the C-14 legislation, was working, and alarm at what was being proposed around C-7. It was a minority of people that supported what was being planned, and yet that was what was moved ahead.
Well, this brings us into something else too, and that is, how is this changing the relationship between, the doctor-patient relationship?
Yeah. So what's really frightening about the Canadian euthanasia legislation is that it has, the way the legislation is worded, it allows for death through euthanasia to be offered as a first-line medical treatment. How is death ever a first-line medical treatment, regardless of your personal views? Just even if you want to be a good doctor, how is that evidence-based medicine? So and most doctors are not aware that this is what this legislation allows. So, and the way it does that is it says, the person has to have, grievous and irremediable medical conditions, with a declining capabilities. They have to have suffering that's irremediable, but they only have to be informed of their options for care. So they just have to be provided with information on what their options are to address their underlying illness. For example, a person with rheumatoid arthritis, like diabetes. These are conditions that now will make you eligible for MAID if it's causing you irremediable suffering, in your opinion, because it's a subjective, autonomous decision under this legislation on an individual patient's perspective. But they just have to know, you could check your sugars multiple times a day and give yourself insulin injections, or you could do this, or, oral hypoglycemic drug, which probably won't work at all because you're needing the insulin, or you could have euthanasia. Like, that's literally what this legislation proposes or allows for, that you inform someone about their options, and the euthanasia proponents are pushing that doctors have to bring up euthanasia as one of those options, like not a person asking for it, that we bring it up like it's like any other medical treatment. And then the person can choose, I don't really want to be on insulin and check my sugars. I can't afford the insulin. Like, there's many, I don't have access to palliative care. I don't have access to a chronic pain specialist. I have chronic pain from my cerebral palsy. But so I'm going to choose death. And so a doctor could be in the position where they have a person before them who has a treatable medical condition. They haven't even tried first or second line evidence-based medical therapies, but this person may request euthanasia, or if they change the regulatory policies as they're indicating we may have to suggest it. And the person will say, I want that. And then you're supposed to facilitate someone becoming dead when you know that there are things you could do to help them. It's just fundamentally changing the nature of medicine. Never mind the trust that's inherent in the doctor-patient relationship. Like, I don't know if I could go to a doctor who's going to tell me that I would be better off dead. Like, I don't know how I would ever trust that person. I want someone who's going to give me all the options for, in order of like most success, least side effects that are, evidence-based options for my care, so that I can live and focus on my wellness. And vulnerable Canadians, persons who've been made vulnerable by the healthcare system or discrimination in the healthcare system, racialized and marginalized people living with disabilities who don't have access to good care. Those people are going to be put at major risk with this. They don't. How could they go to a doctor who's going to tell them that their disability alone makes them eligible for euthanasia, that inherently says your life isn't worth living?
Yeah, inherently says that you have such a low quality of life that there's no point. Mm-hmm.
Yeah, exactly. Yeah, and they've said that during the Senate testimonies. They've been very vocal, the voices of marginalized Canadians who are saying, this is discriminating against our right to life. But they haven't been heard. It's violating the UN Convention of the Rights of Persons with Disabilities. But again, the government hasn't listened.
Father John?
So with this new legislation and all that you've been speaking about, if a doctor is opposed to mercy killing, we know that many of them are they going to be forced to either do mercy killing themselves or to make a referral to another physician that does mercy killing?
Yes, so that's a two-part question. So the Canadian euthanasia legislation, now which is C7, does say that no physician will be forced to provide euthanasia, meaning give the lethal injection itself. But there's no protection under the federal law that prevents physicians from being forced to participate and facilitate euthanasia by either their college requiring them to bring it up as an option, which I'll come back to, or to do an effective referral, or to make sure they're hooked in with someone who's going to be able to provide it if that person isn't willing to do the lethal injection themselves. So in the federal legislation, there are no protections from that perspective. We worked really hard to try to get that built into the Senate amendments, but there was an amendment proposed by Senator Plett, but it was voted down. They said at that debate that this was a matter of provincial jurisdiction. But in Canada, there's only one province who has legislation to provide conscience protection for physicians, and that's Manitoba. And no other province has legislation. The provincial regulatory colleges for physicians and surgeons in each province sets the rules about what is required for doctor participation in facilitating euthanasia and your professional obligations as a physician to the patient. And two provinces in Canada, Ontario and Nova Scotia, both require an effective referral, which is a referral is a recommendation that a doctor provides, and finding a physician who's capable and has good skill. Like, you don't just send someone to someone is going to do a botched job. It is a recommendation that this is the person who's going to provide that type of care the person needs. And so, a referral is very much a form of participation and facilitation in euthanasia. And so many physicians, regardless of their own personal moral views, professionally, because of the way this legislation is worded, would not be able to participate and facilitate euthanasia when a person before them could, as I mentioned earlier, could have something easily treatable that hasn't been tried yet. So it's going to affect way more doctors than the way the provinces have kind of labeled that this is all about religion, and then use that to marginalize physicians that have religious views and moral views that aren't in keeping with providing euthanasia. But many doctors have professional views that are not in keeping, that made euthanasia is a first-line medical treatment, or if there's no requirement for it to be a last resort. In other countries, and I forgot to say this earlier, I'm digressing a little bit, but in other countries who have opened up euthanasia beyond those who are in their last months of life, so Belgium and the Netherlands and Luxembourg, they have made it a measure of last resort. And I'm not condoning that, but I'm just to show the difference between Canada and those other countries, where here it could be chosen first line. The person has the autonomous right to say, I don't want those treatments, I want euthanasia. In those other countries, doctors are required to say they have exhausted all medical therapies to alleviate that person's suffering. That's going to put many doctors in a very difficult position in Canada, regardless of their personal views. And the colleges are trying to say that an objection to euthanasia is a doctor's personal view. Well, for many doctors, as I said, it could be your professional view that this is not good medicine or in the best interest of a patient. So the issue of conscience is a much bigger issue now for many more doctors, and we really need to ensure that there are protections put in place at the provincial level from forcing doctors to participate in euthanasia and facilitating it. I know many doctors who are very worried about what has been said at the Senate testimony for the Federation of Medical Regulatory Authorities of Canada. That's the kind of association who oversees the provincial medical colleges who regulate doctors, has said that they support this concept of duty to inform, which means that a doctor would have a duty to inform a patient who's eligible for euthanasia that it's an option. So that's what I was referring to earlier, that anyone, when you're talking about their treatment options, if they have a serious illness, should be informed that euthanasia is just one of those other options. And if the colleges change the regulations as they're indicating they might, that's going to be a major problem for many doctors who will have to leave medicine. How could they, in good conscience, recommend someone better off, be better off dead? It's wild. But more importantly is the risk of coercion to our patients. Patients that don't have access to good care, that don't have access to palliative care, that are being discriminated against by the healthcare system, and yet we're going to tell them they should get euthanasia. That might be just the push that a person needs to choose it if a doctor suggests it.
Right. I wonder, Dr. Tu, but looking at other both healthcare professionals, but also students that are entering into these professions, even we're talking pharmacy, nursing, as well as medicine. This is putting them in a situation where they're collaborating as well. I mean, what
Absolutely.
about the conscience rights there?
Absolutely. It's not just a problem for doctors. Of course, I'm speaking about the physician lens because that's my practice. But absolutely.
But I mean, as a person who works with teams,
Yes, absolutely. It affects the entire team, including the volunteers, the cleaners. Everybody is impacted by this, and any legislation that's put in place, and it needs to be legislation because colleges can change their policies on women, even the nursing and pharmacy colleges, around what involvement is expected of those professionals. For example, like dispensing the lethal drugs, right, that are used in euthanasia, in the pharmacist, the taxi drivers who might have to deliver the drugs to a person's home. Like, there are many, many layers of this. That there needs to be, significant, robust measures put in place to say that nobody should be forced to participate in ending someone's life through euthanasia who's not want to. And right now there's literally no way in Canada for that, except for physicians in Manitoba, basically. There's no other protections in place. That's another thing that we need to advocate for as a general public.
Mm-hmm. That's, but of course, part of the difficulty here is that the level of ignorance about this whole situation is absolutely massive. It really is. I mean, I wonder if you can, our time is drawing to a close, but I wonder if you could share a couple of sort of good news stories with our listeners about your work and your ministry that illustrate really what a gift palliative care is to them and to our society and our country.
Absolutely. I think, it sounds pretty dismal what we're talking about for sure. But, when you're on the ground caring for people and their families, the work is just so profound, and that's definitely what keeps me going day after day, even though, working in a country with legalized euthanasia, facing that on a day-to-day basis can be quite demoralizing. But then you're before a person and their family, and to be able to see the healing that takes place in dying and in illness is quite profound. That people find reconnection, healing of past traumas, coming to terms with difficult things they've navigated in their life. There's so much healing that happens even in the last weeks of life, that as someone even in the last months of life, that there can be just so much joy. And joy is different than happiness, as we know. There can be so much joy and healing that happens. And it's such a great privilege to be a small part of that and accompany people, facilitate some of those conversations with, long lost family members, or coming to terms with no longer being the breadwinner for their family, but finding grace and dignity in now having your family care for you, and that you matter, that they matter just because of who they are as a person, not because of what they can or cannot do. And that's something that just strikes me so much in the people I have the privilege to work with, is that really comes out, that it's, so much of our society is focused on what you do and what you contribute, and not who you are as a person inherently valued and loved by your family. And so that is the joy that comes out as people face, a different reality that they're it's so beautiful. I wanted to read a quote, if it's okay. So the founder of the hospice palliative care movement, Dame Cicely Saunders.
I remember meeting her
in London. Did you meet her? That's amazing.
Yes, I did.
And she said, and this is it's a core value of palliative hospice palliative care: you matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to help you live until you die. And that is just like the profound hallmark of palliative care, and it's something that inspires me every day, that you matter because you are you. And that is what we see so much happens in those last months and weeks of life, is that people are able to find value in themselves inherently and be loved for who they are.
Well, thank you very much, Dr. Leonie, for joining us today. And I think, one of the people that I admired through all my work in pro-life is Dame Cicely Saunders. She was a extremely impressive person. I remember meeting her as a teenager, and I was struck that she was one of the best listeners I ever met in my life. She would just listen and be intent, on the person. And I think it shows with that, to say that, we will recognize you as gift, and honor you as a gift, as a full person in your own right. So it really was a pleasure having you on our program today, and we want to assure you of God's continued blessing on your work and on the work that so many of your confreres are doing throughout the country. And I mean that both, as I said earlier, the physicians, but all the rest of the teams that are working so diligently here as well. So for our listeners, I'd like to make everyone aware that supporting Priests for Life Canada is open to everyone, clergy and laity alike. And because, excuse me, the voice is going on me. I'll leave that to Father John. He can finish up the rest.
Sure. Well, because we're not underwritten by any organization, we rely on the generosity of all Catholics and people of goodwill. So please consider donating to Priests for Life Canada today. If you wish to donate, you can do so on our website at priestsforlifecanada.com, all one word, priestsforlifecanada.com, or by calling us toll-free at 1-888-300-2007. Priests for Life is a registered charity, and as such, it can issue annual tax receipts for all donations. We'd also like to send you our newsletter that we send out 6 times a year. It will keep you informed about pro-life issues across Canada. And we'll end our program with a prayer. God of power and might, wisdom and justice, through you authority is rightly administers, laws are enacted, and judgment is decreed. Assist with your spirit of counsel and fortitude the leaders of our nation. May they always seek the ways of righteousness, justice, and mercy. Grant that they may be enabled by your powerful protection to lead our country with honesty and integrity. We ask this through Christ our Lord. Amen. Well, this concludes our session for today. We thank our listeners and supporters for tuning in. Please check out our Facebook, our Twitter, our Instagram, and visit our website at priestsforlifecanada.com for all the latest pro-life news and information, as well as access to our other podcasts. Don't forget that the next episode of the Pro-Life Hour will drop the second Thursday of the month, and we hope that you'll be able to tune in. Until next time, God bless.